Okay guys, so this is a very fast PowerPoint just touching upon adrenal glands. This is not something that we scan a lot of in our normal day-to-day life as a sonographer, but if we are scanning a pediatric patient or we are scanning an infant and we're in the pediatric world, this is something that we may be evaluating a little bit more. We also want to be aware that if we happen to see the adrenal glands on an adult patient, chances are there's something wrong. We do not see normal adrenal glands on an adult. We do see normal adrenal glands on a small child, but we do not see them on an adult. So if we are scanning and we happen to visualize the adrenal glands, we need to question if something else is going on. Now, just a little bit of anatomy. We're not really going to get too much into the composition of the adrenal glands, but basically these develop very early on in utero and embryology, so about 6 weeks gestation, they are going to start and finish developing. We tend to divide the anatomy of the adrenal glands into a micro level and a macro level. So in the bigger picture of things, the adrenal glands are going to be paired organs, meaning we have a left and a right, and they are retroperitoneal structures. They typically are going to sit superior to the kidneys, as you can see on this diagram here. So if you're doing an abdomen, you're doing a renal exam, we don't normally see the adrenal glands. If we do see something that resembles the adrenal glands superior to either kidney, we are questioning what's going on. On a micro level, we have the adrenal cortex and the adrenal medulla. Now, the adrenal medulla, that's going to be the central portion of these glands, and they are going to be responsible for producing epinephrine, adrenaline, all of those kind of like fight or flight hormones, which we'll talk about in a minute. And then our cortex, that's going to be our outer component of the gland. And our cortex is actually divided by 3 different zones or 3 different layers. These layers are going to be responsible for producing some of the other hormones that our adrenal glands are responsible for producing. So sex hormones, metabolic hormones, those are all going to be coming from the adrenal cortex. Now, our zones, we have our zona glomerulosa, that is our outermost zone. We then have our middle zone, that's our zona, I'm not even going to attempt to say that word, guys, fasciculata. It sounds like a Starbucks drink. Fasciculata. We're gonna go with that. And then we have our innermost layer, which is going to be touching upon the medulla. That's our reticularis, our zona reticularis. We can have some variants of the adrenal glands, and really the only thing that is very common in terms of variants is going to be agenesis, so meaning you just are not born with one of them. You potentially could be born without both of them, but you're going to have some serious hormonal imbalances. And as we know, our hormones are responsible for really affecting pretty much every organ in our body. So, that would lead to some further complications. Our sonographic appearance, so as I've said about 3 times already, we are not evaluating the adrenal glands unless there is something abnormal or we are scanning a young child. So these are not identifiable in adults, enlarged and variable in size depending on the age of the young patient. So right after birth, our adrenal glands are going to be super prominent on ultrasound, and then they kind of rapidly decrease in size shortly after birth, but we can still evaluate them in that pediatric state. These are going to be located immediately superior to the kidneys. They kind of sit right on top of the kidney, kind of like a little hat. The left is going to be positioned a little bit more medial in reference to that left kidney than the right side is. And the adrenal gland naturally takes on a V or a Y shape. So you can see in both of those examples, top example is a little bit more V-shaped, kind of like a Pac-Man, and that bottom example kind of looks like a parasitic worm, but that's more of a Y shape. So here we have our V, and here we have our Y. Now, our medulla is going to be a very thin echogenic internal stripe, and the cortex is going to be a little bit more prominent, and the hypoechoic, that's our outer layer. They also kind of look like lymph nodes as well, so we want to be aware of that. Now, on a functional level, we've kind of already said that our adrenal glands are responsible for producing hormones, right? So it's a necessary um, it's a necessary organ that we have for hormonal production. So all of the hormones that come out of the adrenal glands, they're going to help us to regulate our blood pressure, blood sugar, our immune response, our stress response. So they're not just producing, our reproductive hormones or our female hormones. They are producing like a wide range of hormones that affect pretty much every aspect of our functional life. So the cortex, as we said, is going to secrete more of those functional hormones. That's going to be our steroids, our glucocorticoids, our gonadal hormones. So those are going to be our sex and our reproductive hormones, and our mineralocorticoids as well. We don't really need to get into depth too much about the specifics of each hormone, but you need to know where these hormones are coming from in terms of the cortex or the medulla. Now, the medulla, our inner portion, this is going to be more of our flight or fight response, our immune response. This is going to be our epinephrine, our norepinephrine, basically our catecholamines are going to be coming from our medulla, that inner central portion. Now, our laboratory values, kind of like the pancreas, are very important for us to be aware of, especially if we are looking at an adult and we see the adrenal gland. Chances are as because something is wrong, right? So there's some type of hormonal imbalance or shift. Now, we need to be aware of what each of these hormones technically are, what their responsibility is on a basic level. So we're not going to get too crazy with it, like I just said on the previous slide. So our adrenal glands are going to be producing aldosterone, cortisol, our catecholamines, as we said, and then we have some kind of like byproducts of those main hormones. So we have our metanephrines, and then we have our VMA, our vanillomandic acid. Don't really know where that name came from, but very, very interesting process. So aldosterone, this is a type of steroid. This is just a very common steroid. It's going to regulate our salt in our water. And if you remember from anatomy, salt and water levels are very important to our overall blood pressure system. So that is a very important balance, and that plays a role on our kidneys, right? So see how everything biologically is coming back to kind of join together. So aldosterone being produced by our adrenal glands, which is going to affect our salt and water and our blood pressure, therefore, and that is going to be controlled by our kidneys, and that's going to affect our kidneys, and the adrenal glands sit right on top of the kidneys. So everything is working very closely with the neighbors next to it. Also, our cortisol. This is a really big common steroid. This increases the neurologic use of glucose. So we don't want to have too much cortisol, but we don't want to have not enough cortisol. It's a very delicate balance when it comes to this type of steroid hormone. It basically is going to determine how much sugar our brain uses, and it's also going to aid in our fight or flight response. So when we are under stressful situations and we're in those life or death situations, our brain is going to need more cortisol because it's going to be using up more of that glucose in that fight or flight response. We then also have ACTH. This is our adrenocorticotropic hormone. This is going to regulate the production of cortisol. So now this is a very important kind of gatekeeper for cortisol, kind of like when we're going back to the thyroid a little bit, where we have the pituitary gland talking to the hypothalamus, right? That's going to communicate with the thyroid. We're kind of talking about that with the adrenal glands here as well. So the ACTH is basically going to regulate how much cortisol our body has, right? And in those fight or flight responses, it's going to be using more of that cortisol. So these are going to be, basically directly related to each other. We also have catecholamines. These are going to be produced by those stressful situations that we are responding to. So this is not cortisol. This is not ACTH. This is something different, right? This is our epinephrine, our norepinephrine, and our dopamine. These are going to be produced by stress. These aren't useful in stress, but it's produced by the stressful situation. So if we're in a fight or flight response, our ACTH is saying, okay, we need more cortisol, so I'm going to allow the body to produce more cortisol. That cortisol is going to be absorbed and used by our neurologic system. And after all of this happens, after all of this stressful situation occurs, then we are going to see the production of these catecholamines, epinephrine, norepinephrine, dopamine. Now, we also have a byproduct of those catecholamines. So now we have all of these hormones that have been produced by this stressful situation. And as those hormones start to kind of deteriorate and degenerate and time goes by, we then get this byproduct. So now the epinephrine is turning into a metanephrine. The norepinephrine is turning into a metanephrine. The dopamine is turning into a metanephrine. So this is kind of that natural breakdown of those catecholamines. And this is how we excrete those hormones. We do so by urine and blood. So the metanephrines is a little bit easier for our body to kind of excrete out after these stressful situations. And then our VMA, very similar to the metanephrines, it's going to be a byproduct of those stressful environments. But this level is actually useful in detecting what are known as neuroblastomas. And we're going to talk about that in a second. So the abnormal function of the adrenal glands can result in a lot of diseases that you've probably heard of before. So when we have an abnormally hyper-functioning adrenal gland, we are going to be in the ballpark of Cushing's and Conn's disease. Now, Cushing's disease is when we have an actual tumor on the pituitary gland that is causing these elevated levels of ACTH. Now, we just said that ACTH is responsible for the production of cortisol. It keeps everything nice and level, right? It allows for more cortisol to be produced when the body's under stressful situations, but then it keeps the cortisol nice and low when we don't need it, right? Now, if we have a tumor that is secreting ACTH, right? The more ACTH we have, the more it's going to say, yeah, sure, you can produce more cortisol. So then because of that elevated ACTH, we're going to have more cortisol in the body. Now, that's not necessarily a good thing. That's not good for our overall health and metabolism. So we see a lot of illness in those patients in terms of body habitus, metabolic function, cognitive function as well. Now, Conn's disease is going to be the excessive proliferation and production of aldosterone. So that's going to be more closely related to the adrenal gland itself. So the adrenal gland itself is just producing too much aldosterone. Whereas Cushing's disease, there's a pituitary tumor that is resulting in higher levels of ACTH. Therefore, that's tricking the adrenal gland to think that it needs to produce more cortisol. Now, when we have hypofunctioning, meaning it's not functioning as well as it should be, that is when we have Addison's disease. So this is the abnormally low production of cortisol and aldosterone. So here we have two examples of these types of scenarios. If we were to be able to visualize them on ultrasound, the top image, I believe, is Cushing's disease, and we have the enlarged adrenal gland, and the bottom image, I believe, is Conn's disease, where we have the production of aldosterone. But again, we're not really evaluating the function of the adrenal glands. We're not evaluating the physiology or really even the anatomy of the adrenal glands unless we're seeing a particular tumor. So moving into those tumors, of course, with any organ in the body, any organ that has functional tissue, we are going to potentially find adenomas, so benign growths of epithelial tissue. They're asymptomatic, but we can also see these in cases of patients who have Cushing's or Conn's disease. On ultrasound, we'll just see a focal mass, similar echogenicity to the adrenal gland, but also could be similar to the kidney or the liver as well. So variable echogenicity, variable in size. We can see these on one side, we can see see these on both sides. So, really kind of unpredictable, but benign and typical of an adenoma. Next, we have adenocarcinoma, and you're probably thinking, wait a minute, I just heard that in the pancreatic pathology, and you did. So again, your pathology charts are super important as we go through all of these organ systems. So this is a type of malignancy. It's the malignant growth of those epithelial tissues and cells. Clinically, these patients, again, we're talking about Cushing's and Conn's disease. They could also be asymptomatic, and it can also result in precocious puberty. So when you have a tumor that is affecting a gland that is responsible for producing all of your metabolic hormones and your gonadal hormones, that is going to put you into early puberty. So that is precocious puberty before the average onset of puberty. On ultrasound, these masses are going to be variable in size and echogenicity. They're going to be complex. They can have calcifications. And again, we're really looking at the space superior to the kidney. So we want to be looking at that liver-kidney interface, that spleen-kidney interface, making sure that there's no mass hanging out there. Very easy for us to confuse this type of solid tumor with a renal tumor. Right? We'll never 100% know just from ultrasound. So these patients are going to be going for additional imaging. They're going to be going for biopsies or surgical removal. But we need to be aware of these differential diagnoses. I feel like I have a lot of I feel like I have a lot of moments where I need to reflect on how I pronounce things during these lectures, and I don't really realize them until I have to speak to a computer screen by myself. Okay, so next we have neuroblastoma. So this is one of those findings that is going to come back to us again when we get into our renal pathology. So this is technically a tumor that originates from the adrenal gland. Now, we kind of treat it as a urology finding, but on a cellular level, neuroblastomas originate from the adrenal gland. So this is the most common childhood malignancy, period. Okay, super common in kids. It's technically a pediatric sarcoma, and it comes from the medullary tissue of the adrenal gland. So this is something that if we are working in PD, or a PD patient comes in for a renal ultrasound for a palpable mass, chances are if we see a tumor, this is going to be a neuroblastoma. And remember, it does not originate from the kidney. It originates from the adrenal gland. Clinically, the patient could be asymptomatic, but they're usually going to have a palpable mass because these neuroblastomas can get pretty large. They are also going to probably experience weight loss, fever, tachycardia, which is increased heart rate, sweats, hypertension. They could have pallor, which means they're kind of pale or white in their coloration. On ultrasound, we're going to see a focal mass right at that superior portion of the kidney at the interface with either the liver or the spleen. We could see calcifications, and we're going to see renal displacement because of how large these tumors can get. So if you look at our picture here, here's our heterogeneous focal mass, and look how far away from the liver it's pushing the kidney, right? So here's our right kidney all the way over there. And here's our liver. We know that normally we want to see those right next to each other, kind of touching upon each other. So it's a lot of kidney displacement. Next, we have some other acquired conditions that can affect the adrenal glands. Any organ can hemorrhage, right? Any organ that receives vascular supply can hemorrhage. The adrenal gland is no different to that. They can also grow cysts, which, as we know, are typically going to be benign and not worrisome. And then they can also form abscesses. So any organ that is likely to have an infection or inflammation is not immune from getting any type of abscess or pus collection. So with this picture on the bottom, so the top picture actually is a contrast enhanced CT, and this is our liver, here's our IVC, here's our aorta, and here is our cyst on the adrenal gland. Now, if this were at the kidney level, we would see transverse right kidney here. We'd see transverse left kidney here. But we're not seeing that. So we know that we're superior to the level of the kidneys, and that is where we are finding this cyst that is affecting the adrenal gland. Now, picture on the bottom, this is something that we could very likely see in clinical and as a tech, and we would probably look at that and say, okay, wait a minute, is that a liver cyst or is that a kidney cyst? And it's neither, right? Because it's on the adrenal gland, between the liver, between the kidney. Next, we have infectious diseases that we need to be aware of in terms of the adrenal gland. So tuberculosis, this is something that the adrenal glands are very sensitive to. It is a type of bacterial infection. When you guys, you're already working in healthcare, you guys have already had to get TB tests. That's what we are testing for, is for active or latent tuberculosis. It's a type of very easily transmissible bacterial infection. And the adrenal glands are actually the most commonly involved organ in cases of tuberculosis. So really, when we think of tuberculosis, we think of like, oh, a nasty cough, or we can kind of spread it through the air, right? It really does have the most effect on our adrenal glands. So kind of a bizarre relationship there. And it also is going to result from adrenal insufficiency, Addison's disease, right? So when we're not producing enough aldosterone, no. Guys, I'm having a brain fart. When we're not producing enough, why am I thinking of just Cushing's and Conn's disease right now? Please hold. Yeah, okay. Aldosterone and cortisol. Sorry, guys. I know what I'm talking about. Sometimes I just have a rough moment. So that is going to eventually cause that for the adrenal gland as well, right? So it's going to result in that hypofunctioning of that adrenal gland to produce those hormones. We also want to be aware of histoplasmosis, and this we can contract when we inhale fungal spores. Again, can cause adrenal insufficiency. So histoplasmosis, I'm not 100% sure, but I do think that is something that can occur if you were to breathe in black mold. I do think that is what that concern is. When you are living in an environment that has black mold, you can't be in there without a mask. And then cytomegalovirus. This is a lifelong virus that you have. The adrenal glands, again, are going to be very sensitive to this type of virus. It's going to cause adrenal insufficiency and inflammation of the adrenal glands, adrenitis. So these infectious diseases, we're going to come back to these quite a bit, especially when we're learning about OB. And again, this is kind of piecing everything together here, right? The adrenal glands are very prominent in babies, right? So in newborns, in young children. So if we are worried about all of these infectious diseases while our mom is pregnant with us, we want to make sure that we are thinking about our adrenal glands and our hormonal production as we begin to develop. So a lot of information that we most likely are not going to be seeing a lot of out in clinical. You probably will see a neuroblastoma at some point in your career, unfortunately, but for the most part, we're not evaluating adrenal glands. But if you happen to see something in that space between the kidney and either the liver or the spleen, you know that that is, potentially a different organ. You know that that is potentially the adrenal gland and not the liver and not the kidney and not the spleen. So a lot of information that, doesn't really have a clinical component to it, but not too much information to kind of waste your time a little bit.